fraternity gathered here today, to implement your digital or the mHealth program as a medical fraternity, you must take a little step outside, getting your regulator to speak to the telecom regulator to say, hey, if I have to provide digital health, mHealth, this is the kind of demand that we have only as one sector. The second thing in policy terms from a medical point of view is when you have to develop this infrastructure. So all new hospitals or a new infrastructure that you make, ab initio as part of your design of the hospital should integrate the optical fiber connectivity or the wireless connectivity, whether it's inside hospitals or otherwise, so that it is a plug and play. The other part is that we are facing, in policy terms, India has the most stringent policy in terms of EMF exposure, right? 1/10, the WHO, medical fraternity has said that. The WHO specifies the levels, we are at 1/10. And today, imagine, the South Delhi, just for example, South Delhi Municipal Corporation shut down about 10 towers over the weekend, maybe wants to shut down another 50. So in policy terms, what is it? Is that local self-government people want to tax the tower to fill up their coffers. So we are lacking in policy terms a national right-of-way policy. It's something like, you know, RWA folks get up and say this, like a road in front of the society which serves the common network of roads. Hey, I'm scared of EMF exposure despite the best international norms. You take the tower away from here, you shut this road. Imagine you shut the road in front of your, let's say, society. How do you people, how does that society expect to get the network coverage? You want the network coverage, you don't want the tower. It cannot happen. So in policy terms, that's where from the medical fraternity, one great thing, what recently the Secretary Telecom has met with Urban Affairs Secretary, that all government buildings should have a tower and in-building built there. So today at this forum I'm requesting the medical fraternity that a similar dispensation to install towers and in-building in all hospitals across the country will greatly facilitate access and affordability. You know, some of you mentioned that. You know, if I have to imagine if I was dependent on trying to reach out to a practo or to reach out to my doctor through my internet device, which Shashank spoke of, and you shut off the tower. How do you go about doing, providing medical health care? So, you know, and this, the other policy thing is, we talk too much, and the action plan, we have a 600 million target, right? Broadband connections, that too is at 512 and 2 meg. Guys, come on, be realistic. You know, we put too many targets out, and India, itna bada desh hai, we do this, that. On ground, discipline, and if there is a decision, implement. There's too much, you know, I hear the pain that he has. The regulator has to be kind of, you know, revamped. The regulator who regulates that sector. And the good news is that, like a Uber, you know, I took a Uber to come here, and some of the transport problems I tried to overcome that way. Now the sharing economy growing, another policy maybe you can consider, you know, is that cost of medical equipment is expensive. About 10 years back, I heard a German lab offering their lab when India is awake and they are asleep. So if the medical equipment is IP connected, internet connected, equipment lying idle at some part of the world could be put to better use in a sharing economy. And what is the policy for? This is just a thought, but in terms of, you know, how you could use it. And last, I'll sign off by, it's not policy, but lighter notes. So maybe Shashank, you're putting the doctors together for patients. I'm sure a lot of, like Shadi.com, a lot of doctors want to link up with other doctors in the, you know, what? Marriage field, I know, it may be just a sidebar conversation on your side. So these are some of the policy things that we from the telecom sector and the broadband sector are looking at. And I think the pace of decision making, there's too much talk, less action. We need to get more action on the ground.
Thanks, Vikram. You're always very crisp and blunt. Sushil has come late, so I'm going to punish him. He's going to speak in 3 minutes. what fantastic work he has done. See, all the policies and frameworks we are talking, we have something called M2M, machine to machine in health. Sushil has been the driving force. He is the Deputy Director General of the TEC under Ministry of Communication and IT. They come out with a wonderful report that the Minister released on the 12th of May. In 3 minutes, Sushil, if you can talk about that report, what you did and what are your future plans?
Sorry for the delay.
Don't need to be sorry.
There is a traffic between Delhi and Gurgaon. It has taken more than 1 hour from Delhi to Gurgaon. Actually, in the mid of 2013, this DOT decided that a policy is to be framed on machine-to-machine communication, and the standards are to be finalized. Then the standard work was taken up by Telecom Engineering Center, and the work groups were formed on PPP model, covering having all stakeholders from the industry and telecom service providers, multinational company, IT and ITS, and the standardization bodies. These working groups were in automotive, health, surveillance, and power and gateway and architecture. As there will be billions of devices, and there is a projection that 50 billion devices are expected by 2020, and Indian share will be around 250 million. And in health domain, India may have around 10 billion devices. Then the first technical report has been released in May 2015, and in all the 5 vertical groups, and health is one of them. In health, we are having machine-to-machine communication in remote health management. As number of devices exist, and the sensors will be used in the devices, and there are 3 challenges for using the billions of sensors and devices worldwide and even in India. Like first is the deployment of IPv6 that the DOT has already taken up, and the IPv6 deployment is network is being upgraded by the telecom service provider and network operators. And even the pan area network, we expect that the chipset manufacturers will have either the dual stack or the IPv6 stack. Second one is the battery of the sensors. A lot of research is going on this issue, that the sensor should be self-sustainable, or it should have long battery life. And third one is the standards, so that the devices should be interoperable. There should be interoperability at the network level, application level, and the device level. And as far as we have studied for the remote health management and for wellness of the person, this personal health devices, and which is using the continuous standards. Continua has developed a number of standards which have been approved by ITU, and these are being harmonized in 1M2M also. And if the harmonization work gets completed and further 1M2M goes to ITU, and these M2M standards are approved by International Telecom Union, they may be adopted globally. And these devices may revolutionize the health scenario, at least in the rural areas where 74% of the population lives, and we don't have the hospitals and the doctors. The vital parameters of the patient can be transmitted over the network, like we are having the NOFA network being built up even up to the villages, and villages will be having Wi-Fi also. This work is already going on, and these parameters can be stored in the cloud, and the doctors can monitor these parameters and further advise the patients. So the work is further going on. We are further studying the continuous standards, ITU standards, and the further harmonization being done in 1M2M. 1M2M is creating a service layer where the data from all the vertical devices will be stored and how it will go. So second level of reports are expected sometime in the month of November, and we expect we will be able to finalize something in the health, at least in the health domain. Thank you.
Thanks, Sushilji. I think all of those who are really concerned about machine-to-machine standards, I would like you all to connect with Sushilji after this session, because this is totally done in partnership with people like you who are contributing to the actual standard formulation. There's also
these reports are available on TEC website, and this www.tec.gov.in/technical-report. And I will request that the people may download these reports and may study and further contribute their expertise to the working groups.
Thank you. So the last word is always with the government. Very dear friend Sanjeev Kumar, it's in his personal capacity, I would suggest, because he's also part of the group that is finalizing the health policy. So sir, last 5 minutes for you, and after that we have told them to ask questions. Though we're running out of time, we'll definitely have to take questions. Over to you.
Thank you, Rajan. And this Digital India conference is very important to us. I am accompanied by 9 of my colleagues from Healthcare Technology Division, which looks after application of initiatives like we are discussing here into health. Then we have Health Management Information System and Healthcare Financing. These are 3 of the 8 divisions we have in my organization, National Health Resource Center. There are 3 things which I heard from the group. One is supportive environment. Second is policy framework. And the third is, if an initiative is available, why is it available for years and years and the last person is still not benefiting? How and what we are doing to scale it up immediately so that everybody can benefit. Look, coming to supporting environment, and I will resist from going into IT policy requirement and supportive. Others have talked about it and they know much better. I will confine to health and the interface between health and what is happening in IT and how health can benefit. Looking at the supportive environment, health for all, 1978 they started talking about health for all. Then late 90s and last about 10 years they started talking about universal health care. Everybody should have access to health care. Recently, and the current policy which is being revised is looking at health as a right of everybody. So the environment is changing towards making health universal. Everybody should have access to health. But when you reflect on our ancient Indian culture, for 11 years, many times a day, when I used to go to class, to hospital, to clinics, I used to read Sharira Madhyam Khalu Dharm Sadhanam. AIMS logo, at the bottom you have Sharira Madhyam Khalu Dharm Sadhanam. It is your body through which you will be able to perform all your duties. Dharma is not religion in our language, it is your duty. So when you translate into religion, that doesn't really reflect what we say. Then you keep hearing Sarve Santu Niramaya. And I grew up in an Arya Samaji family. Jivema Sharda Shatam, Shruniyam Sharda Shatam, Prabhuvam Sharda Shatam. For 100 years, for 5,000 years, we in India have been saying that let's live for 100 years and with good hearing, with good eyesight and healthy lifestyle. So this is the environment. The rest of the world realized only about 25, 30 years back, but it was there in our culture. Let's revive that. Let's get everybody in the government and everybody on the street concerned about the health which is there in our ancient culture. And recent push to yoga. I started doing yoga when I was 12 years. Every one of us was doing, but it has been brought to official forum recently, and that's complete lifestyle. Yoga is yam, niyam, patyahar. That is your lifestyle. What do you eat? How much you sleep? And what do you do from morning to evening? Then is asan pranayam. We get confined to asan pranayam as yoga. And then the last 3 components are asan, pranayam, dhyana, dharana and samadhi. That is these are the 8 components of yoga. So if you look at yoga in a comprehensive manner, you have healthy lifestyle. So this is another enabling environment and supportive environment we have. So this is on supporting environment to have universal health care. And when you look at each one of us in the room, we fall only in 2 categories. One is those who are healthy, and some of us have some ailment or the other. What do you want to do for those who are healthy? Keep them healthy. That should be the focus. Unfortunately, when we talk of health, we talk of only disease. And I at times jokingly tell my colleagues in the health ministry, it is not a ministry of health, it is ministry of disease. You have programs for disease control, you have programs for disease prevention, you have programs for disease cure and treatment. What about health? What about those who are healthy? What are you doing to keep them healthy? So we need to look at those who are healthy, and you have a lot of devices. I carry a mobile phone, it has health. And my target is every year I should walk 10,000 steps. I don't meet it. Normally, once in a week only I meet that target of 10,000 steps. So you have devices which are already, but why everybody is not using those devices? We have to push in that direction. Each one of us monitor. Those of us who are healthy, what are we doing to stay healthy through yoga, through other devices, and in your pocket your mobile phone which will give you how well you are doing. What you eat. Again, your mobile phone, you enter the information, you know how many calories you are eating, what fat you are taking, are we doing the right dietary practices which are promoted for healthy lifestyle. So this is to keep those who need to be healthy and need to continue to be healthy. Bimari na pade, that should be our approach. Those who are sick, what do you need for them? They should get access to the person who can advise them what needs to be done. I went to Tripura, to a remote PHC, and there was an optometrist sitting with equipment and a child she was examining, and I said, are you an ophthalmologist? No, I am not an ophthalmologist, I am only an optometrist, I can use this equipment. 15 minutes later, I came back after taking the round of the PHC, and she had a prescription for the child. You are not a doctor, how did you give the prescription? She said, no, we have a doctor sitting in Tripura. He has in the capital city who has given the prescription. He is looking at all what I am doing, 200 kilometers from where I am, and here is the prescription given by an then this initiative started in 2007. Why did it take 2015 to reach to all the CHCs in Tripura? Forget about rest of the country. The technology was there. It was being done, and they have only 19 ophthalmologists in the whole state. And next year, 9 of them are going to retire, so they will have only 10. And they are still able to give this service. So that is one example. Second is Rajasthan. I went around many PHCs, CHCs and hospitals. After the clinic was over, the pharmacist was entering all the prescriptions. And anybody sitting in Jaipur will know which medicines are moving faster, which medicines they are going to run out of stock, and make arrangement to get those medicines. But why not every state, every health facility has this software so that they can monitor availability of medicines? So availability of medicine is the second initiative. Third is quality. The quality of care being provided in healthcare facilities, that also can be monitored. It's happening in many parts. Fourth and the most important aspect of care is 65 million people in India go below poverty line because of expenditure on health. And as some of you said, 60 to 70% of that expenditure is on medicine. Rajasthan is able to buy generic medicine, give free medicine. Why not every citizen in India get free medicine through the same initiative? Coming to the platform available to scale it up, government is very serious about it. We had a National Health Innovation Summit. Dr. S.D. Gupta was there, and I am sure some of you in the audience were also there. They bring together all states and union territories and private sector, present what you are doing. They evaluated those which are replicable, which are cost effective, and effective in doing what they claim they are doing, can be scaled up. Come make a presentation, and all these are available on the website of National Health System Resource Center, all these innovations. Second thing which the minister launched in Shimla on 2nd of July is National Health Innovation Portal. If you have a breakthrough technology, you think it is great, go to the website of capital N, capital H, capital I, small n, P. Go to the website, upload it there. There will be a group which will look at it. It will be evaluated. If it is effective, replicable, and costly, it is it is within affordable limits, and it addresses the burden of disease. They will evaluate it, and then if it is evaluated as effective, government will provide funding under National Health Mission to the states to scale it up in the whole state. So this is the platform which is available for scaling up, and I feel pain. I feel pain when you have devices, you have technology, somebody in some corner of India is using, but it is not being scaled up. So this is the policy framework and the enabling environment and a platform to scale it up in a short period of time. Thank you.
Thank you so much. Very well said. See, right from the angels to the government, everyone has money. So don't worry. Though we are out of time, I would still take 3 questions quickly. Yep.
I just want to leave this forum with one thought. We're talking about enabling internet, we're talking about enabling mobile, we're talking about digitization. In this very country, if you look at financial services, you have a company called Paytm, which has leveraged financial technology. In this very country, you have a company called Naukri, which has brought employment to the net, right? Job searching to the net. In this very country, you have something called Flipkart, which we all use. And these are all internet enabled. We have Make My Trip, which has enabled travel on technology. I think what we all need desperately, and there's an opportunity, is a $1 billion valuation company in the healthcare. And I think that's the aspiration I'd like to leave.
So we could quickly take 3 questions. Don't make comments, just if you have questions. If